Hello, everyone. This is John White again on the Rural Matters podcast. This is one of the leading podcasts on rural education, health, and the economy in rural America. And we thank you so much for joining us again for what I think is going to be a very timely and important conversation today. When we have this podcast twice a month, we try to talk with decision makers, thought leaders, innovators, and stakeholders throughout the rural community, and people like yourselves who have a stake and are such big contributors to the life and vitality of rural communities. Please share with your friends that you can listen to the Rural Matters podcast on iTunes, Google Play, Stitcher, and any other place where you find your favorite podcast. And if you have great ideas for a future podcast, please send them to us by email at ruralmatterspodcast@gmail.com. So we have two guests with us today. We have Dr. Robert Pack. Dr. Pack is the Associate Dean of Academic Affairs and a Professor of Community and Behavioral Health at East Tennessee State University. We also have Summer Sage with us. She is the Board President of the Virginia Rural Health Association. So welcome to both of you, and please introduce yourselves a little further.
All right. Thank you so much, John. My name is Summer Sage. I am the current Virginia Rural Health Association Board President. I also sit on the Virginia Developmental Disabilities Board and work with rural families in Virginia in the area of special education and special needs, and have been really excited this year that the Rural Health Association has been focusing on seeking collaborative solutions to known issues in our rural communities, and doing that with the local decision and change makers. And that's kind of what brought us here today, and bringing Dr. Pack in to bring some of his research and best practices in the opioid epidemic.
Great. Thanks. My name is Rob Pack. You've already covered my official titles. Another one that I have is Executive Director of the Center for Prescription Drug Abuse Prevention and Treatment at East Tennessee State University College of Public Health, and it's actually an interprofessional center at the Academic Health Science Center. I would say that that center's work is focused on taking evidence-based interventions all up and down the continuum of addiction and trying to get them to be used at scale, which basically means at the greatest scale possible. And that's our focus. We believe that there are many excellent interventions that can be brought to bear against the opioid epidemic, and we need to be using them better. There are also other things that we need to do to learn, and so we continue to research new techniques as well.
So Dr. Pack, you are actually keynoting, or one of the keynote speakers at the Virginia Rural Health Association conference going on this year in Virginia. Would you please kind of describe your keynote address and what you'll be talking about when it's entitled Intersections, Finding the Big Picture in Little Communities?
Yeah, glad to. So I delivered the address this morning prior to being on this podcast. And so the address was essentially the story of our collaborative team on campus and its connection to the community through something called the Prescription Drug Abuse and Misuse Working Group. And the working group is a large collaborative of both researchers on campus as well as medical practitioners and pharmacists in the community, and coalition leaders and politicians and just engaged community citizens. It has over 210 members at this point. In any given month, we might have 30 to 50 people show up at a meeting. We meet on second Tuesdays every month, and what we do is we basically just engage with each other and talk about what we have going on and try to learn from each other, while we also sort of have the ethic of encouraging the use of best practices, and not just best practices, but proven evidence-based interventions that have solid outcomes.
So let me just kind of take that a little further. The topic of today's podcast, I think we're going to focus on the prescription drug abuse and opioid crisis. And Summer, I don't know if you want to talk a little bit further about what you're seeing in Virginia and what the impact has been of the opioid crisis on communities and in schools.
Well, I think what I would like to say is that one of the things that's been brought to our attention was the lack of clear communication between the patient and the prescriber, and just having that conversation of, is the drug I'm taking an opioid? It seems like a simple concept, but coming from a mom who tries to have those regular complex conversations with my own doctor for my son who has autism. So, sometimes it's difficult to wrap your head around all these concepts and things that you're discussing and the different prescriptions that you're dealing with on a daily basis. Just making sure that you're on the same communication page has been a key issue. And that's what we've focused lately in our grant research with Virginia Rural Health Association and this HRSA grant that we applied for, is to develop an opioid education program where we're actually helping the provider or the community, the hospital community liaison come in and do a train the trainer model on how to have these conversations with the patients as you come in, to say, what is it that you're on? What are these drugs? What are the ramifications of them? And kind of build on that communication, conversation, and structure that out as an education program. And one of the things that I think Dr. Pack touched on today was that there has been a lot of research done into programs that are, what works already, rather than reinventing the wheel. Let's go into and see what are the things that have been vetted that we know have teeth behind them. And there's a database, I think, that you had mentioned.
Sure, yeah. The National Registry of Evidence-Based Programs and Practices. It's the NREP is the acronym, but it's out of the Substance Abuse and Mental Health Services Administration. There's over 400 evidence-based interventions there that are sort of searchable. You can search by keyword, and for example, if you want to do something for teens, or if you want to do something for youth or young adults, if you want to focus on opioids or marijuana or whatever, there's all kinds of different interventions that are there that have proven outcomes against control groups and the best using the best type of methods that are available for this type of study. And you can even go there and access plain language summaries of the results in sort of non-scientific language. And because one of the things I think that limits us as scientists is having to speak in this really complicated manner for publication, for peer-reviewed publication, that's not always accessible by everybody. And I think that NREP does a great job of taking that language and really making it consumable for everybody. They even do economic analyses, like how much you can expect to save if you implement this type of study. It's an excellent resource. It's one of many such resources that are put forward by the government that demonstrate the long-standing commitment of different scientific teams around the country to address these problems. It's a compendium, if you will, of all these assets. There's a number of different ones out of the NIH, National Institutes of Health, that are very, very good. The one that's focused on substance abuse programming is the SAMHSA NREP website.
So you bring up a good frame of reference here. So we're talking to the general public on a podcast. I want to make sure everyone understands what you're talking about. Just back up a little bit for me, maybe Summer, and explain what's behind. Why did you apply for the HRSA grant? Explain what HRSA and the purpose of the grant is, what led you to apply, and what you hope to achieve, or what does this grant give you the potential to achieve?
The potential of this grant is, again, to take a very complex issue, which is a statewide epidemic of opioid abuse that we're seeing in certain counties, 6 overdoses a day in some of the areas. And I know that number is accurate, but I can't exactly tell you which county. And not knowing how to combat that, or how to take the Revive program that we've been using in the state to help with that overdose issue, and kind of come from how are we stemming the overflow, and how do we instead combat it from the very beginning and start the conversation up front with when these drugs are being prescribed. Does the individual know what's being prescribed? Are we having that conversation in a way that we're actually communicating it? I'm a lay person. I don't know. I can't list to you a dozen different opioids, but I am the person that would be receiving a prescription for them. So I'm going to be that patient that needs to have that communication made clear to me that the prescription I'm receiving has an addiction possibility, or is an opioid, or what are the different things I need to know as a patient.
So Summer, I just want to add that this is a vital issue that you're bringing up. There's an existing grant that we've been working on for about 4 years now that's specific to this topic of patient communication with the physician, patient communication with the dispensing agent like the pharmacist, and then the communication between the pharmacist and the doctor. So the prescriber, the dispenser, and the patient. That little triad. The greatest problem, I think, in that is this mistaken belief that communication actually takes place.
Right.
And what we've found a number of times in different studies is that between the pharmacist and the doctor, there's very little communication. In fact, each of them thinks that the other one is doing it wrong. And between the patient and the doctor, there's very little communication taking place. The doctor thinks that some of it is going on, but it's really not. And the patient doesn't perceive it as such. And so one of our graduate students, actually Stephanie Mathis, we'll say Dr. Stephanie Mathis, because she just defended her dissertation on Monday, which was exactly on this issue of patient and physician communication, the patient's perceptions of it and the physician's perception of it. She's even developed a pretty elaborate model for how this goes that has to do with misperceptions actually, and we're testing that model using some quantitative data, and we're actually pilot testing that survey right now. So our aim is to develop evidence-based solutions to this issue. But in the meantime, we need to be doing something. I think that's a good time to begin maybe thinking through like what might work in that setting, to practice some of those potential intervention modules. I'd like to actually work with you guys to help develop some of this, because it's of vital importance and of significant interest to us, our research team. So I didn't know that you had this grant actually until today. So I'm delighted to hear about it.
Yeah. And
the mention being made on the podcast. That's terrific.
Right. Good job, John.
There you go.
Dr. Pack, can you take this further? Can you connect it to pre-K to 12 education or higher education? How does this come into education?
If you think about the continuum of addiction from sort of non-use to really bad outcomes, in public health, we should be focused on keeping people from using illicit substances or misusing even prescription drugs, because we know now through, unfortunately, far too many data sources that many people have fallen into the trap of opioid use disorder through prescribed drugs as well as other paths, right? But we need to keep people out of that whole initiation place. We need to keep them from any initiation in the first place. And one of the best ways to do that is through really good pre-risk youth prevention programs. So at the 5th and 6th grade level, for example, to take primary prevention programs that are focused on resiliency, skill building, refusal skills, for example, future orientation, goal setting, things that are done at the 5th and 6th grade level, because, kids begin to move into this riskier behavior around 12, 13, 14 years old. Right. And there's some excellent interventions that are out there for younger kids. And if we can give them better skills at an early age, you can change the shape of the curve, if you will, during those risky years as teens. And so
what are some of those interventions that you think people might want to ask about at school?
Well, one of the most famous studies in this regard is the Seattle Social Development Study. It's really, really fascinating. It's done by Hawkins and Catalano. There's been a number, I'm going to say dozens of different groups that have spun out of this. But those interventions that were done with the kids, I'm talking about future orientation, goal setting, resiliency, that kind of pack these skills around the kids. And compared to other youth that were not in those communities, and that reasonably comparable control-like communities. This is a quasi-experimental study, so you can't have a true control condition, but in a control community, if you will. These kids did better on all kinds of different risk behaviors, be it substance use, violence, risky sexual behavior, all kinds of different risk behaviors were prevented by engaging in this type of intervention compared to the control condition. And so there's really good evidence for this too over multiple decades. And it's just painful sometimes to see folks struggling to start something new. And this work has already been done in many cases. The Adolescent Transitions Program is another one. You can find this one on the NREP website. It's kind of focused on some of those same type of skills, but it's done through primary care settings. And rural health is a perfect place to do this if you have, for example, an interdisciplinary team-based care model. If, for example, you have a psychologist or social worker, you could train them on the Adolescent Transitions Program, and it does the same kind of thing for kids who might be at risk. And so, John, I guess if I'm going to try to leave you with a point to keep, is that before folks feel like this is hopeless, before folks feel like there's nothing that they can do, and before they maybe engage in creating something new, seek out the best evidence for the type of approach you're looking for, and see if there's something, if it's not perfect, something that may be modified slightly that is logically going to work in your situation. So I would just say that there's just been a lot of work that's been done already. We still need to do some other things for sure. For example, what we were talking about earlier with respect to communication, those interventions are not yet fully developed. But we have a lot of different ideas, and we can build on some things that have already been done in the past. So anyway, I think implementing things at the 5th and 6th grade level and earlier is very, very good, and doing it on a community-wide basis and really making that intersection between the community, the school system, and other agents for change. I would encourage your connection to universities and other places that are focused on creating new interventions as well.
And did you say a lot of this research can be found on the National Rural Health Association website?
No, the National Registry of Evidence-Based Programs and Practices.
I see. Okay.
You can find almost everything there that I was just talking about, and that's out of SAMHSA, the Substance Abuse and Mental Health Services Administration. And just remember, SAMHSA, NREPP, and NREP is easy. It's just evidence-based programs. Is if you Google a couple of those words, it'll come up.
Great. I appreciate that. That'll help a lot of our listeners. And of course, if anyone has questions following this podcast, please send them to us by email at ruralmatterspodcast@gmail.com. Well, I want to thank both of you, Dr. Pack and Summer Sage, for joining us. That's about all the time we have for this segment. We're going to take a break and then we'll be back. But thanks again for joining us, and I'm sure we'll be talking again soon.
I'm delighted to be here.
Thank you so much, John.
Our sponsor today is the Virginia Rural Health Association. The Virginia Rural Health Association is a 501c3 not-for-profit organization working for the 2.5 million people who call rural Virginia their home. Our mission is to improve the health of rural Virginians through education, advocacy, and fostering cooperative partnerships. VRHA has a 20-year history of bringing together rural health stakeholders in Virginia to develop strategic plans and implement projects, including the creation of the Virginia Rural Health Clinic Coalition and the Virginia Rural Health Telecommunications Consortium. VRHA has more than 1,000 members statewide, including hospitals, clinics, schools of medicine and nursing, government entities, nonprofit organizations, concerned citizens, and more. VRHA provides its members with information on state and federal issues, educational opportunities, and rural health advocacy. VRHA recently received a federal grant to address the opioid crisis in rural Virginia. They will use funds from this funding opportunity to develop a curriculum for hospitals and clinics to provide to their high-risk patients, enabling Virginia's rural communities to better address the opioid abuse crisis at a local level. VRHA is an affiliate of the National Rural Health Association. Learn more at vrha.org.
So our second guest today on the second half of the Rural Matters podcast is Maggie Alawani. She is the Government Affairs and Policy Vice President for the National Rural Health Association. And I guess you could say that she's going to give us a view from the Hill. She'll be our expert on policy changes at the federal level and talk about how this plays out locally. So, Maggie, welcome to the program. And why don't you just tell us a little bit more about yourself and your work?
Thank you so much. I'm really happy to be here. As you said, I am the Vice President of Government Affairs and Policy for a National Rural Healthcare Association. We are sort of the umbrella group of rural America. We represent physicians, hospitals, rural health clinics, all different types of providers, educators in rural America, and certainly the patients. So what we try to advance to Congress is talk about the importance of rural health care, not only for the patients in rural America, but also for the vibrancy of the local rural economy.
Absolutely. So what do you see as kind of the key needs for healthcare reform in rural areas?
Well, the Affordable Care Act, or Obamacare, as some people call it, was certainly an important step forward. And as an association, we strongly support the goals of the Affordable Care Act to get more people insured. Rural America, per capita, have a higher percentage of uninsured individuals, higher percentage of folks in poverty, higher percentage of folks that are older and sicker, higher percentages of chronic disease. So there is a tremendous need for getting access to health care. Unfortunately, some of the ways that the Affordable Care Act really has unfolded, the ACA really isn't being fulfilled in the way I believe it was envisioned. So during these last few weeks, when Congress has talked about repeal and replace, as an association, we strongly defend the goals of the Affordable Care Act, but we strongly advance that it doesn't need to be repealed, but it really needs to be fixed in rural America. So the promise of accessing healthcare can really be realized for millions of patients across the country. We've got 20% of the population that lives in rural America, but they're scattered over 95% of the landmass. So the sheer geography of just providing access to care is daunting. And when you couple on top of that, the patient population health, as I said, older, poorer, and sicker, and on top of that, some of the great tragedies that we have going on in this country, such as the opioid crisis and the rural hospital closure crisis, what we're really seeing is a crisis in rural healthcare that I haven't seen since I've been working in rural healthcare in Washington, D.C. for over 20 years now.
So you said something about it hasn't quite unfolded as planned or as intended. Talk about that a little more from the local level.
Sure. So the goal of the Affordable Care Act, whether you support it or not, the goal was to get people insured. The 34 million folks in this country that weren't insured. It was going to be done really one of two ways. You're either going to significantly expand Medicaid, or you're going to make people buy insurance on those exchanges. Both of those really haven't worked as effectively as they probably could in rural America. The first, Medicaid expansion, no one saw coming, really, the Supreme Court's decision and that ability for a state to opt out of the expansion of insurance coverage. And what we see are really some of the most rural, some of the most poor, some of the most population health challenged states in the country who have opted out of expanding Medicaid. That's causing, in part, a rural hospital closure crisis. I say that because, unfortunately, those people are still getting sick, even though they don't have health care coverage. They show up in that hospital emergency room, but the hospital isn't getting reimbursed for it. Bad debt has actually gone up by 50% among rural hospitals since the Affordable Care Act has gone into effect. Another reason that the ACA isn't being realized in rural America the way it could have been is that on these private markets where people were supposed to be able to go and choose a health plan that made sense for them, there's really no choice. There's really no plan competition. We're seeing a lot of the big insurance companies cherry pick their markets, and they've been pulling out of rural markets across the country, saying that they're not making enough money. In fact, 70% of the counties that these big insurers have pulled out of have been in rural counties, leaving no choice. And the other fact that we're seeing is that when people do, and a lot of this goes back to education, which I know is the core of what you are advancing, really goes to a lack of health literacy. So many people who wonderfully are able to maybe buy insurance for the first time and get that federal subsidy don't really understand how the insurance process may work, don't really understand that maybe that high deductible plan doesn't work for them. So what happens is, more often than not, rural America is buying that, $5,000, maybe $7,500 high deductible plan. They get sick. They show up into their local rural hospital emergency room. They get stabilized. All that's great. But the rules of being that local rural hospital is they're just a stabilizing area. They can't hold you. So they transfer you to another facility. And here's the rub. What happens is that patient can't afford their high deductible. They can't pay that local rural hospital. But by the time they're transferred to that urban or suburban facility, their deductible, even though it hasn't been paid, it has technically been met. And so their insurance actually starts to kick in. It's another reason that really we find a lot of these small rural hospitals end up subsidizing the care for these patients. So again, bad debt after the ACA has really gone up tremendously high among rural hospitals. And what we're seeing is this escalation of rural hospital closures. Again, it's not the goals of the ACA. The goals of the ACA are great. It's just the way they were implemented. Either states chose not to expand Medicaid, or we're letting these insurance companies, just pull out of these rural markets or have such crazy high deductibles. And that's something really that we're trying to address with this Congress and the administration.
Why should our listeners in urban areas be concerned about the healthcare in rural communities? Does it sound like there are options there that may impact both?
Well, they certainly should care about it. It is 20% of our population. If we did not have rural America, we wouldn't have our agriculture industry. We wouldn't have our fisheries industry. We wouldn't have our timber industry. Without rural America, there would not be a U.S. economy. They're critically important, but boy, they're struggling now like really never before. And what we see is difficulties that I said are tremendous right now. What we see is chronic poverty. We started the war on poverty a little over 50 years ago now, and President Johnson went to some of the poorest counties, and before that, candidate Kennedy went to some of the poorest counties in the country, saying that, we have to do something about chronic poverty in rural America. Well, over 50 years later, those are still the poorest counties in the country. And here's the thing that's so incredibly troubling. If you look at what happened after 2008, when we hit this great recession, where we had a national economic collapse, temporarily, and almost a worldwide economic collapse. But if you look at the rebound and the jobs that have come back, 90 to 95% of the jobs that have come back after the recession have been in urban and suburban areas. There is still a great recession in rural America. And that is all part of the story. And when you take away their health care and that critical part of the country, it's like pulling one of a leg out of a three-legged stool. It's the schools, it's the hospital, it's the churches, as one hospital CEO said. That is the heart of a rural community. If you pull one of those legs off, the entire community falls. And that is what's so important to understand about rural America. The education system, the school system are all so importantly tied together. And they're facing, as I said, the challenges, the lack of jobs. You know what is a stable employer? If we can stop these hospitals from closing in rural America, it's the healthcare system in rural America. So not only is there this great need and a tremendous amount of workforce shortages in rural areas, so even a bigger need that is being unmet, which is important for us to improve education and get people in these rural areas. But if you don't have that, as I said, you're going to see a national economy that suffers if we don't have that small investment in rural America.
You're so right. I mean, schools are often the center of community life in rural communities, and the hospital is vital as a service provider, but also as an employer. And I even think about the careers that young people can see in their communities if they want to stay in their communities, whether it's through health IT or telehealth. Can you talk a little bit more about that connection between healthcare and education and how vital the ACA has been for many rural schools as well?
It's absolutely so critically important. So much of the issues, I did work for 3 different senators in rural states. And what we long discovered is that it's so important to educate, to train folks at the youngest of age to understand the importance of their rural community, to understand the important connection of providing quality health care in a rural community. If you can get that training early on, things like area health education centers, try to kind of grow your own, get folks in an early age interested in math and sciences and being able to get the training they need. What we find is it's so critical to have training, to have education in rural communities. So much of the issue of workforce shortages really is a systemic problem in our education system, where we send so many of our young folks away from rural communities to get educated, to go to nursing school, to go to medical school in these urban areas. And obviously there's nothing wrong with that. But the problem is that they don't get a lot of the training, the residency training, especially in physicians in rural areas. We find that more often than not, if you can get residency programs, if you can get that local training, more often than not, you can get physicians to practice in that rural community. And if you can get one physician to practice in a rural community, it could be a tremendous economic boon to the entire rural economy. What we're trying to do is work with medical schools to improve rural track training programs to get folks out to those small rural hospitals, rural health clinics, to experience the rural community in a great way it is to practice. And additionally, it's really important to get kids at a young age, again, interested in healthcare IT. As you said, I think that's an excellent point. That is really the promise. Problems have gotten more severe in rural America because of things like the opioid epidemic, the chronic poverty, the mortality gaps that are growing between rural and urban. We can improve some of those, I'm confident, but something that was there, is there, and maybe always will be there are those workforce shortage issues. That's why the promise of telemedicine is so tremendous, where we can finally get outreach to those programs. But there's still a lot of barriers, and telemedicine, telehealth hasn't reached its full potential yet. Some of that has to do with reimbursement issues. Some of that has to do with licensure issues. But some of those methods, you don't need a whole lot of technology. It's absolutely amazing, some of the programs that are being done with just a simple iPad or Skyping individual, just some abilities to do telepsychiatry with that basic kind of technology has been doing absolute wonders in rural America. So again, the promise is great out there, but we need to capture kids at a very young age and get them interested in that. It's also important in rural America where the school and healthcare is so closely tied. As you said, the schools, they're really the hub of a rural community along with the hospital. We can do so much education, so much outreach through the schools, through the nurses, through other healthcare providers within the school to just help folks with basic pediatric care, which is the most cost-effective way to provide care to any age of a population. But kids are just so great because you can get them healthy at such a low-cost way to do it. You really get the bang for the buck. But they can also help educate their parents and provide some of that health literacy, which is so important in rural America. And part of the reason that we find that the ACA maybe isn't working the way it was intended, and people are buying maybe plans that don't make sense for them, some of those higher deductible plans. So again, in no other parts of the country is it more important to link healthcare with education than in rural America.
You're so right. And I think about the doctor shortage in rural communities, and I think about the teacher shortage in rural communities and the residency programs, and those types of grow your own strategies actually work because students grow up in those communities. They don't want to leave their family. Many of them want to come back and contribute to their communities. And if we can show them the career paths in their communities and that they are cutting edge and that they make a difference, those students and those young people are more likely to stay. So I think you're right on point there.
Completely agree. And I think it's important, if you can get those kids to come back, to invest in their rural communities, again, it's going to make the community vibrant. Because if you don't have adequate health care in a community, you're not going to attract new businesses. You're not going to keep families there. You're not going to keep retirees there. And again, to go back to this hospital closure crisis, what we're seeing when these hospitals close, almost always these doctors are hospital-based. So if the hospital closes, the doctors leave, the nurses leave, the pharmacists leave. We're getting these medical deserts forming across the country. And it really is just a death sentence for so many of these rural communities.
Yep, you're right. Before we close, we're running out of time here, but give me something positive. What are the opportunities that residents and citizens can do to engage with their representatives, with the healthcare system? How can we give them something positive to end on, and how the listeners can make a difference in this process?
Two tremendous positives out there. Every study that you do in rural America, patients are so happy with the healthcare they receive. They're so happy with the patient outcomes. They love that kind of personal care they get from their healthcare providers. They want to help their local rural providers be there and want to invest in the community. But the big positive that I want to let folks know, and it's interesting because it's sort of a result of the election, is that more than ever, Republicans and Democrats alike know that rural America matters. I think the November election was a surprise to everyone inside the Beltway. And as Senator Chuck Schumer said at an event very recently, and I'm paraphrasing, he says, if we've learned anything from the November election, is that we can't listen to rural America enough. So we've got a voice now in Washington, D.C., and it's so critical that we unite together and utilize this precious time now to really make the most of this opportunity and really invest in rural America, really invest in rural education and rural health care.
You're so right. I've heard so many people say that this is a unique moment, a unique opportunity to lift your voice, talk to your representatives, and try to make a difference, a positive difference for rural America. So I want to thank you for joining us on the program today on the Rural Matters podcast, Maggie. The information you provided was terrific, and maybe we'll have you back again to talk about federal policy sometime soon.
Looking forward to it. Thank you so much.
Thank you. Well, that's all we have time for today. Let me just say that if anyone wants more information on topics we discussed, or if you have ideas for future topics for the program, email us at ruralmatterspodcast@gmail.com. And we'd appreciate you if you would rate us on iTunes and tell us how we're doing there, and tell your friends about the program so that we can engage more people in this conversation about rural matters across America. This episode of Rural Matters Podcast is produced by Michael Levin Epstein and Susan Sempeles. So I want to thank you for listening, and we'll talk to you again soon on the next episode of Rural Matters. Have a good day, everyone.